Hello, my name is Kim Eagle from acc.org. I'm from Ann Arbor, Michigan. I'm joined today by Dr. Deepak Bhatt from Boston and Dr. Payal Kohli from Colorado. Today is day one highlights of the American Heart Association meeting. There are a couple of important trials that are being reported today that we wanted to talk about. Let's start, Deepak, with a trial called Avatar. Love the title.
Yeah, I'm with you. This is really a great trial acronym. It's also a great trial. Very important question, I think, getting at that patient with asymptomatic but severe aortic stenosis. And they did a good job here. Modest size trial, a little over 150 patients, but really carefully selected. These are all folks with severe AS, the mean gradient greater than or equal to 40 milligrams. Or rather millimeters of mercury, the aortic valve area less than 1 centimeter squared. So the real deal. And sometimes people say, oh, asymptomatic, you should have exercised them, then they would have been symptomatic, but they did exercise testing here. So these are folks that really were, as best as one could tell, truly asymptomatic. And then they were randomized to either conservative therapy or early surgery. And the results, I thought, were pretty striking. Again, with the caveat that it's a modest sized trial, but a significant benefit for the early surgery. The number of events for the primary endpoint, it was a primary composite of all-cause death, heart failure, acute MI stroke, 26 in the conservative arm, 13 in early surgery. So about half the rate. Again, limited in terms of the sample size, but seems believable to me, and I think sort of fits with our evolving picture of when patients have severe valvular heart disease, even when asymptomatic, probably better to operate early.
I was impressed with the difference in death. That obviously, if it's a hospitalization endpoint, that's a softer endpoint. But I think there were 7 deaths in the watchful waiting arm, which is striking and surprising. And I think it probably calls to mind that we need a larger trial, but this certainly sets us up for that to try to really get a final answer on this. Payal, any thoughts?
Yeah, I would say 2 things. The first, I really want to applaud the investigators for recruitment, because obviously randomizing people to surgery when they're asymptomatic, it's a tough thing to recruit patients for. So kudos to them for recruiting these patients. But secondly, I want to say that I think this really reflects, as Deepak just said, a very different approach to managing valvular heart disease. Up until now, it's really been very reactive. We've been waiting for symptoms, waiting for something, LV dilation, to tell us that it's time to intervene. But I think the shift has really become to a more proactive approach, which means stratifying people, understanding their disease process, and trying to intervene early.
I recall many years ago, didn't Dr. Braunwald say that the biggest risk for a patient with asymptomatic aortic stenosis was an encounter with a cardiac surgeon?
Yes, that's a widely disseminated quote. And I think that wisdom still applies here. I mean, these results are terrific, like you alluded to, Kim, 16 versus 9 deaths. But you can imagine if the surgery was done by surgeons that weren't as skilled, or the patients were less carefully selected, maybe patients with multiple comorbidities that would be bad surgical protoplasm, then the results could have backfired. So, some caveats before just applying these data too quickly or broadly. And there's also, work going on with TAVR in similar populations. So we'll see what that shows.
Great. Let's move on to the second trial we wanted to discuss today. And again, it's involving cardiac surgery. And the question of whether we should do tricuspid valve repair at the same time we're doing mitral valve repair. Payal, tell us about this trial.
Yes, so I think this answers a really important clinical question, which all of us have struggled with. When we send our patients with degenerative mitral valve disease, should they get tricuspid surgery at the same time? So this was a study that screened 5,208 patients, but only randomized 401 again. So a lot of screen failures during the study, but patients either had to have, in addition to their mitral valve disease, moderate TR, or less than moderate TR, but with annular dilatation, suggesting that they may potentially progress to having more clinically significant TR. And they were randomized to mitral valve surgery alone or mitral valve surgery plus a tricuspid valve annuloplasty. They were followed for about 2 years. Now, notably, 90% of the patients going into the study had normal RV function at the time that they were randomized. And about a third of them met the criteria through the moderate TR. About 2/3 had the annular dilatation. And again, the results here were so impressive. But really only to one endpoint. So there was a 63% reduction in the primary composite endpoint of death, reoperation for tricuspid regurgitation, or progressive tricuspid regurgitation. But most of that was really driven by progressive tricuspid regurgitation. There was no difference in mortality, no difference in quality of life, higher need for pacemaker, and 34 minutes of cardiopulmonary bypass time. So this really asks the question of whether we ought to do this just to prevent tricuspid valve disease from progressing. That's the first thought that came to my mind. The second was, do we just need a longer follow-up to start to see some of those curves start to diverge with respect to the actual endpoints? But the third thing I found really interesting about this, Kim and Deepak, was the fact that we learned something about the tricuspid valve. Because what we learned is that the people that benefited the most were those that had moderate TR rather than those that had annular dilatation. So really seems to be two different types of physiology at play here.
Great. Wonderful analysis. I agree with you totally. A longer follow-up would have perhaps allowed us to see if this was clinically important in terms of right heart failure. And we really need longer term data to answer the question. We have to applaud the trialists. You know, doing randomized trials in heart surgery is just so hard. And it's really exciting. These two trials, I think, call to mind that the clinical trial business around heart surgery has really matured a lot. And it's exciting to see. Any comments, Deepak?
Well, yeah, no, I agree with you. I would commend the investigators too. Not easy to do randomized trials in surgery in general, cardiac surgery in particular. I think there's going to be a lot more data coming out about tricuspid regurgitation in years to come. There's much excitement in the interventional space with ways to reduce TR, and a lot of patients with really bad TR are not operative candidates because there's bad TR, their liver's taken a hit, maybe some cardiac cirrhosis, not a good candidate for general anesthesia or a surgical procedure. And in those sorts of patients, already the preliminary data, non-randomized preliminary data, show that tricuspid valve clipping is feasible. It seems to be associated with better outcomes than what would otherwise happen. And there are also tricuspid valve replacement technologies that are being developed, not just clipping them, but even replacing them percutaneously, as is being tested with the mitral. So I think we're going to learn a lot about those devices, obviously, in those ongoing trials, but we'll learn a lot more about the underlying disease, when to intervene, which types of patients should we intervene when it's moderate TR, you know, should we treat annular dilatation differently? So there's a lot that we'll be learning, and these surgical and percutaneous trials will add greatly to our knowledge base.
Yeah, I agree. It's a renaissance moment in valve therapies. And ironically, the cardiac surgeons and interventional structural cardiologists are painting the canvas together. And I think it portends great news for patients in the future. So 2 great trials. Thank you, Deepak and Payal, for wonderful summaries. This is Kim Eagle for ACC.org on day 1 of the AHA, and we're out.